Okay, picture this. You walk onto the ward, it's early in your shift, and you can just tell something is wrong. You see a colleague, could be a doctor, could be a nurse, someone experienced, and they're just leaning against the counter, completely distraught. They're tearful, hands are shaking, and you find out they made a pretty significant medication error a couple of hours back. Now, thankfully, the patient is stable, but the error happened, and your colleague is, well, they look devastated, distracted, maybe even unsafe to carry on. So the question is, in that moment, what is your first professional move?
That scenario, that's the absolute crucible, isn't it? It's where all the theory gets put to the test. And it's something everyone in healthcare will face.
Absolutely.
And you have to realize you've essentially got two patients in that moment. The one who got the wrong medication and your colleague.
The colleague.
Yes. They've become what we call a second victim. They are going through this profound emotional distress, guilt, shame, fear. And that distress, it makes them really vulnerable to making another error.
A second victim. I think that phrase alone completely reframes it. It pulls you out of a sort of punitive mindset.
It has to. And that's what this deep dive is all about. It's about that mandatory professional duty you have, how you support your colleague while never, ever compromising patient safety.
Because they're not separate things.
Not at all. The sources we're looking at, especially for anyone preparing for exams like the MSRA, they make it so clear. Failing to support your distressed colleague is a patient safety failure. Welfare and safety are completely intertwined.
So we're going to unpack the principles here. We're looking for that structured approach that blends, I guess, human compassion with some really rigorous accountability.
That's the mission. We need to get to the core idea, which is this. Compassion plus just culture. You support the person and the learning. That's how you protect patients, enable candor, and you turn that distress into safer practice for everyone.
Okay, let's get into it. Before we even talk about an action plan, we need the right mindset, right? The sources hammer home this idea of a just culture. What does that actually mean when you're on the ward and emotions are high?
It's the absolute foundation. A just culture is basically a promise. It's a commitment to a fair and consistent response when things go wrong.
So people feel safe to speak up.
Exactly. Staff know that if they report an honest mistake, something that happened because of, system pressures or a confusing process, they won't get hit with immediate unfair blame.
That sounds great in theory, but I can imagine it's hard in practice. How do you draw the line between a blameworthy act and a genuine system issue, especially when a patient's been harmed?
And that's the real challenge. It's why just culture is so vital. It stops us from jumping to the easy conclusion, which is always let's blame the person. It forces us to ask the hard questions first. Was the medication packaging confusing? Were we short-staffed? Were the guidelines clear? It's only after you look at the system that you can identify if there was, say, recklessness or a deliberate violation, and those are handled very differently.
So supporting the colleague isn't the soft option. It's actually the key to unlocking the real reason it happened.
Precisely. If staff are scared, they hide mistakes. And if mistakes are hidden, the system can never learn. It's as simple as that. And this all ties directly back to GMC standards.
Right. Good medical practice.
Good medical practice 2024. It says we have to contribute to a culture that protects patient safety and learning. And it says we have to treat colleagues with respect. So supporting that distressed colleague, it's not just a nice thing to do, it's a core professional duty.
Okay, let's make this super practical. You walk into that scene we described. What's the framework? We need that clear first, next, last set of actions.
Right. This is the operational side, the 5 steps that you have to take. And step 1, the immediate non-negotiable step, is you check their welfare and fitness to practice.
Right away.
If that colleague is visibly distressed, distracted, shaky, you have to intervene. You pause their duties. You arrange for someone competent to cover them. Now,
Just want to underline that. Taking them off clinical duties isn't a punishment. It's an act of protection.
it's an act of protection for everyone, for the patient and for the colleague. You're removing them from an environment where a second, maybe even worse, error could happen. It has to be done sensitively, but it has to be done.
Okay, so that's step 1. They're safe. The ward is safe. What's next?
Step 2 is about practical management. You arrange safe cover and get a senior review. This isn't something you handle on your own.
No.
You get the consultant, the registrar, the senior nurse in charge involved immediately. They need to manage the clinical aftermath and lead the formal debrief.
Okay, now for step 3. This is the one I think causes a lot of anxiety. Candour, the duty to be open. How do you manage that when your colleague is in pieces?
This is critical. Step 3 is the mandatory duty to enable a timely and, crucially, a supported candor conversation.
Supported.
Yes, the conversation with the patient or their family has to happen, and it has to happen quickly. But your role isn't to push them into a room alone, it's to coach them, to help them prepare, maybe offer to be in the room with them.
And the sources are very specific about what that conversation should be, aren't they?
They are. You have to make sure the colleague understands the NHS Resolution guidance. Saying sorry and apologizing for the distress caused and explaining what happened is not an admission of legal liability.
That's such an important point.
It is. Candor is about honesty. It's not about accepting blame before there's even been an investigation. Leaving them to do it alone is a recipe for a delayed or a really poorly handled disclosure.
Makes perfect sense. Okay, so after the candor conversation, what's next for the colleague's welfare?
So that brings us to step 4, which is about long-term welfare and signposting. The immediate crisis might pass, but that second victim experience can last a long time. So you have to connect them to the proper support systems, occupational health, the hospital's well-being hub, maybe a peer support network. And for trainees, their educational supervisor is key for that ongoing mentorship.
Right. And finally, step 5, making sure this doesn't just get forgotten.
Exactly. Step 5 is all about systems learning. You have to document and drive the improvements. That means recording objective facts, logging the incident on the national system LFPSC.
Learning from patient safety events.
That's it. And then critically, you make sure actions are set with owners and timelines. This is all part of the Patient Safety Incident Response Framework, or PSIRF. It ensures every incident generates real, concrete change.
Okay, that's a fantastic 5-step framework, but in the heat of the moment, that's a lot to remember. This is where a good memory hook comes in.
It is, and we've synthesized this whole process down into a really robust mnemonic: care staff.
Care staff. I like it. Let's break it down.
Okay, so the first part is the immediate response. C is for checking their welfare and safety. A is for arrange cover. R is for review and debrief with a senior. And E is for enable candor.
CARE. That covers the person and the patient.
Then you move to the system and the culture. That's the staff F part. S is for signpost support. T is for track the actions for system fixes. A is for apply just culture. And F is for feedback and follow-up.
That's brilliant. It covers everything: the person, the patient, the system. And if you need something even quicker, you've got the 3 Cs.
The 3 pillars, yeah. Care for the colleague, candor with the patient, and culture, making sure it's a just culture. If you hit those 3, you're meeting the highest professional standard.
Let's talk about the tripwires, the things that, if you see them, you have to act on immediately, the red flags.
The red flags are signals that the whole process is breaking down. And the first, most urgent one, we've touched on it already, a colleague who is too distressed to practice safely. You see that, you must act. Pausing their duties is mandatory.
What about cultural red flags? Things you see other people doing wrong.
That's a huge one. Any pressure from anyone senior or otherwise to hide the incident or to skip the candor process, that has to be challenged and escalated immediately. Your duty of candor to the patient trumps any internal pressure.
And what about that blame culture we talked about?
Yes. Seeing things like punitive emails or gossip, someone being named and shamed in a meeting, that is a massive organizational red flag. Your job is to step in, halt that, and redirect everyone back to a non-punitive fact-finding approach. That blame stuff just destroys psychological safety.
And the final one, the admin red flag.
Simple. No documentation. If you see there's no plan to log the incident on LFPSC, that's a red flag. From a systems point of view, if it's not logged, it effectively didn't happen. No learning can occur.
So to make this really practical, what are the actual words you might use, those key phrases?
When you first approach that colleague, you lead with empathy and safety. Something like, "Are you okay to continue? Let's step aside for a minute. I'm going to get someone to cover for us while we debrief. I'm here for you."
Straightforward. Addresses the risk, offers support.
Exactly. And then when it comes to candor, you frame it as a team effort. We need to be open with the patient today. Let's plan what to say together, and I can be there with you if you'd like. We'll do this together.
That makes it a shared responsibility, not a solo punishment.
And that's the essence of support.
Okay, we know what the right answers are. But a big part of exams like the MSRA SJT is spotting the wrong ones. What are the common, low-scoring trap answers?
The traps are almost always the options that feel easier in the moment but are professionally just wrong. They fail on safety or on culture or on learning.
So give me the first one, the one that ignores welfare.
The classic trap is, tell them to carry on and be more careful since the patient is stable. This scores terribly because it completely ignores their emotional state. You're putting a distracted, impaired colleague back in a position to cause more harm. It's a massive patient safety risk.
What about the opposite extreme, the punitive response?
Yeah, the trap that looks like. Publicly shame them and hand over as a warning to others. I mean, that's the absolute opposite of a just culture. It's cruel, unprofessional, and it guarantees nobody will ever report an error to you again. You've just destroyed any chance of creating a learning culture.
Then there's the trap of trying to protect your colleague too much, right? The cover-up.
Yes, the trap might be phrased as, advise them not to log it because it could affect their career.
Yeah.
This is a huge failure. It violates the duty of candor and the duty to report for system learning. It puts an individual's career ahead of patient safety, which is always the wrong choice.
And finally, the trap related to candor itself.
That's the one that says, insist that they go apologize to the patient alone immediately. It sounds proactive, but it's poor support. Timely disclosure is vital, yes, but unsupported disclosure is often ineffective and can make a bad situation worse. You're abandoning a vulnerable colleague.
So the golden rule really is clear. That combination of humane support plus accountability through just culture and then the system learning, that beats blame, silence, or abandonment every single time. It's the only defensible approach.
It's the most robust framework we have. You protect the colleague, you protect the patient, and you protect the entire system from making the same mistake again. By the way, if this is a topic you're focusing on for the MSRA, there are some great worked examples and detailed guides over on pastmsra.com which really break these scenarios down.
Great resource. Okay, as we wrap this up, let's just nail down the 3 absolute key takeaways for anyone listening.
First one, protect immediate safety, always. Check welfare, and if there is any doubt, arrange cover. Taking someone off duties is protection, not punishment.
Number 2.
Model a just culture and enable supported candor. Be the person who ensures the conversation with the patient happens, but happens with support and preparation.
And the 3rd.
Document, log, and follow through. Make sure the objective facts are recorded, it's logged on LFPSC, and that you see the learning actions through to completion. That's the PSIRF mandate.
Fantastic. Those 3 actions really define a top-tier professional response.
They do. And just as a final thought to leave you with, the official frameworks, like PSIRF, now mandate that staff are involved in the response. They treat them as second victims. So the deeper question this raises for all of us is, what more needs to change in the culture of the NHS, beyond just a good debrief, to make sure every single staff member feels fundamentally safe enough to always speak up?
A really crucial question for all of us to think about in our own practice. You now have a clear, high-scoring framework for one of the toughest professional scenarios. Make sure you review those resources we've mentioned, like the PSIRF guidance and the GMC principles, to really embed this. Thanks for joining us for this deep dive.